Everybody. I am Katie Loviska. I'm an advanced dental therapist working here in wonderful Minnesota. The next part of the CE is going to be a short, I'm hoping, but if any of you know me very well, that could be very difficult, PowerPoint presentation. And we're just going to go over kind of all things dental therapy. And Sai will be running the presentation for me. So if I forget to say slide, have patience with me. Thank you, Joe, for the wonderful introduction. Thank you, University of Minnesota, for doing this with the Minnesota Dental Therapy Association. It's been really fun, and I'm so excited to have this first ever dental therapy CE. And thank you, as always, to all the panelists. I had to really pester some people to do this, and they so graciously decided to take time out of their lives to do this. And thank you all for joining. So, dental therapists, a new generation of oral health providers, part 1, an introduction. It's very exciting. Today will be a little bit more information-based. The second session, which is going to be held on February 10th, again at 7 p.m., it's going to be another panel with different providers, different dentists, and billing personnel, and it's going to be a lot more questions and Q&A. So please look forward and sign up for that one also. So I'm Katie Loviska. Oh, slide, please. I have an undergraduate degree in biology from the University of Minnesota, and then I obtained my master's of dental therapy. I was part of the first graduating class from the University of Minnesota back in 2011. I became a certified advanced dental therapist in 2015. I have worked for a few different clinics over the past decade, and I've been privileged to work mainly for health partners for the past 8 years. And I just switched to Southside Dental Care in Southern Minneapolis back in October, which is an FQHC. And I have been very privileged to speak on behalf of my passion for dental therapy, kind of all across the country in several states. I have spoken at various House and Senate hearings to pass legislation and just gone and talked about that dental therapy is real and it exists and it's working in Minnesota. So it's been a lot of fun. I am also the current president of the Minnesota Dental Association. And yeah, so that's enough about me. Slide. Again, nothing to disclose. Pew was generous to give us a very nice grant to help us do a CE course and a few other really fun things that the association is doing. We have a brand new website too, so if anyone wants to go check that out, and we'll have a lot more fun stuff coming up here in 2021. But otherwise, I have no financial interest or any commercial products throughout the presentation. So we can go to the next slide. So again, we're just going to go over what is dental therapy, why was it created, and just over the past decade, how far it's come, where we're practicing. I'll go over what a collaborative management agreement is. And then a few statistics. Again, a lot of that will be from the panel next time and today too. Slide, please. As I'm sure many of you are aware, there are a lot of dental disparities. So why dental therapy? Even as early as the 1890s, we're seeing evidence of dental decay and access to care issues. Then the Surgeon General reports started coming out, and one of the actions included increasing the oral health workforce capacity to supply dental professionals to shortage areas, such as rural and urban areas and areas with racial, ethnic, and poor populations. Slide, please. And then I think one interesting fact is the U.S. Department of Health in 2015 projected that we'll have a shortage nationally of dentists, about 15,600, with a lot of the baby boomers that are retiring. And just that alone, just needing more providers when we already have like an access to care issues is going to be something where, you know, how are we going to help? What tools in our toolbox can we use, you know, to further help with that issue? Slide, please. And then there's a most prevalent disease among children, which is caries, cavities, early childhood caries also. It affects a lot of the social, economical, physical, and it's great because dental therapists, a lot of our scope of practice encompasses pediatrics. And so we've been able to help with that also and trying to help control this childhood disease and really get a grasp on breaking the cycle and trying to help kids. And it's one of my favorite parts of the jobs, and I'm sure you'll hear more from our panel about that later. Slide, please. What is a dental therapist? We are not special therapists for dentists and or special therapists for patients with a lot of dental anxiety, and or anyone that massages and specializes in the jaw or facial muscles. Gotten that over the past decade. Dental therapy actually exists in 50 other countries in the world, and they're called dental therapists there. So when it started in America, they were thinking of different names like dental nurse, and but they just decided to stick with dental therapist. So that's kind of where the name came from. I like this definition that Pew gives. So more than 56 million people in the United States live in areas with a dentist shortage. Dental therapy is a proven solution that has helped increase access to care. Dental therapists are mid-level providers who deliver preventative and routine restorative treatments at clinics, hospitals, mobile units, schools, nursing homes, and veteran homes to people who would otherwise struggle to get access to care. Next slide, please. This is kind of just a really short, fun video that Pew did. If none of you have seen it, it's just very entertaining. It's only 2.5 minutes. So we're going to see if Sai can get that up and running here quickly. If you need to, just take a quick break.
Our enthusiasm for going to the dentist has always been lukewarm at best. But for more than 125 million Americans, basic dental care is out of reach. Either because their dentist office is too far from where they live, doesn't accept their insurance, or isn't open at the right time. Or because they just can't afford it. Left untreated, dental problems can cause serious health issues like heart disease and respiratory infections. It's a problem that costs all of us. In 2014, $1.9 billion of taxpayer money was wasted on preventable ER visits, even though hospitals can do little to treat dental problems. So how do we solve this problem? To find out, we called up a dental therapist.
My name is Christy Jo Fogarty. I'm a dental therapist with Children's Dental Services in Minneapolis. A dental therapist is much like a nurse practitioner or physician's assistant. We work under the supervision of a dentist. We can do just about any kind of filling, stainless steel crowns. We see children, we see pregnant women, we see veterans, we see seniors, any people who have trouble accessing dental care. I travel really all over the state. Unfortunately, I do see rampant tooth decay every day. But I also know that I'm reaching those who are most in need.
With more than 63 million people in the US living in areas with dentist shortages, dental therapists like Christy Jo are making a big difference.
In my job every day, I am fortunate that I'm able to treat those most in need, those children who are most likely to fall through the cracks of the dental system that we currently have. And quite often I'm paid in lots and lots of hugs.
More people in Minnesota are getting the care they need. One private practice increased its Medicaid patient load 16 times over since bringing dental therapists on board. And in Alaska, where dental therapists also practice, 40,000 people have care that didn't before. More and more states are authorizing or considering dental therapists because they can expand care to people who need it the most. It's time to put dental care in reach for more Americans.
Just a second as we get back to the PowerPoint presentation. Thank you. Okay. So next slide. Okay, just kind of a little overview. A lot of people think dental therapy in America started in Minnesota. It actually started in Alaska back in 2003 is when they started looking at it, and they started caring for patients in 2005. And then Minnesota started looking at it, and they became the first state to actually pass the dental therapy legislation. Next slide, please. This is a timeline that can be found on Pew's website. I think it lays it out very nicely, just kind of how dental therapy has progressed over the last 10 years, how many states that we're in, which is currently 12, I believe. Alaska versus Minnesota. Alaska in 2003, they sent their first cohorts of students to New Zealand to actually attend training. And then the program started in Alaska, where they came back to school in Alaska. And in Alaska, they have to be hired by like a tribe and work for the tribe for 10 years. And Alaska is actually a legislative or federal-based license, where Minnesota is a state-based license. And so that's a bit of a difference too. Alaska, a lot of their, what we affectionately call DHATs, they can travel to Inuit populations that are only accessible one time a year and practice dentistry, where that's not the exact issue in Minnesota. So our scope of practice is a little bit smaller than the Alaska programs. Minnesota, when it passed, had the support of more than 50 different organizations, including the American Dental Hygiene Association, the American Public of Health Association, the American Public Health Dentistry, and Pew Charitable Trust. So kind of a fun outline of how we've progressed over the past 10 years and what state that we're in, states. Next slide, please. This is a very convoluted slide of more or less, I just wanted to show how difficult the legislative process can be. I got to learn a little bit about this in some of my travels. It was amazing that dental therapy passed during the first legislative round in Minnesota. I'm learning how rare that is. Florida, I think, is in its 4th or 5th round alone, trying to pass dental therapy, as are several other states. So this just kind of shows how we went about. All these slides can be available to anybody that needs or would like them. I'll give my email at the end of the CE also. So I won't go through this, but it took a lot of work, and thankfully Minnesota passed it, and the University of Minnesota and Metro State decided to pick up the torch and be the first schools to actually do this in the country, which I'm eternally grateful for. Next slide, please. So there are actually 2 different programs, which is where some of the confusion can come from. So there's the University of Minnesota and the Normandale Metro program. Both are approved by the Minnesota Board of Dentistry. And for both programs, the students have to pass comprehensive competency-based clinical examinations done through credits. The patient board, I think it's important to note, is the exact same as the dental students. We're graded to the exact same degree. There's absolutely no difference. And there's a blind proctor. So they don't know if they're actually grading a dental student or a dental therapy student. Just like the dentist and the dental hygienist in Minnesota and the dental assistants, we have to pass a jurisprudence examination and submit an application for licensure. So some of the confusion can come from both programs graduate dental therapists. The Metro State, I believe it's an 18-month very accelerated program, but you have to be a hygienist first. So they've already gone through the hygiene program, and then they get into the dental therapy program. They graduate as a dental therapist, but their degree is called a Master of Science in Advanced Dental Therapy. The University of Minnesota originally was just a dental therapy master's and bachelor's degree, and they've changed over the years. And so now it's a dual degree program. So you graduate with a bachelor's of science in dental hygiene and then a master's in dental therapy, and it's a 3-year program, and you obtain both. So there can be some confusions with the 2 programs, but both you graduate as a dental therapist. Next slide, please. So then after you graduate, you have to work 2,000 hours under what we call indirect supervision. I'll go over what that is in a second. After you complete the 2,000 hours, you have to create a patient portfolio. You have to take before and after x-rays of certain restorations that you've done. There's an entire list that's available on the Minnesota Board of Dentistry's website, or I could send anybody if they're interested. You have to do a one-on-one interview with the board, and then you have to take an examination. Up until last year, the board did the examination, but now the board is being run through the Commission on Dental Competency Assessments. And so the first round of dental therapists are now taking the exam that way. So once you pass all of that, you can then be certified as an advanced dental therapist. And then next slide, please. So the levels of supervision, if you're a dental therapist, you pretty much work under indirect supervision, which means that everything is required to be done with the knowledge and consent of a dentist, but the dentist has to be in the clinic, has to be in the office. General supervision or procedures are required to be done with the knowledge and consent of a dentist, but the DDS is not required to be in the office, and standing orders can be followed by practitioners, similar to what you would do with x-rays or dental hygienists practicing in a mobile unit or in a school. Next slide, please. So our scope of practice is definitely not as fully encompassing as a dentist. We can pretty much do any restoration, any fillings, any amount of services, any type of material, stainless steel crowns on both permanent and primary teeth. We can make space maintainers, do primary pulpotomies, not pulpectomies, extractions of baby teeth, and then extractions of permanent teeth that are at least class 3 mobile. But that's just for the advanced dental therapist. And then any assessment and treatment planning can only be done by an advanced dental therapist. So we can perform limited exams, periodic exams, and exams for 3-year-olds and under. We cannot do comprehensive new patient exams. That has to be done by a dentist. Advanced dental therapists can refer to specialists, and advanced dental therapists can dispense, administer, and provide medications, but dental therapists and advanced dental therapists cannot prescribe. Next slide, please. One of the big things that some of the other states are following to some degree, I think Maine has the exact same language in their bill, is dental therapists are required to practice in settings that serve low income and underserved patients, or are located in dental health professional shortage areas. And they have to maintain an underserved patient base of at least 50%. When we first graduated, this freaked a lot of people out because their practice wasn't 50%, but they still saw state-based insurance. And it's important to note that 50% of the dental therapists' patients have to fall under these categories, not 50% of the clinic's patients. So that's just an important differentiation there. Next slide, please. This is just one of the many graphs done by the Minnesota Department of Health in a study they did back in 2019 that pretty much just shows that there has been absolutely no issues with dental therapy serving the population that we were created to serve. On a daily basis, we're serving who we were intended to serve. There's a link that I'll give to anybody that wants to look. It's a very long survey and it kind of breaks everything down for people, but so it hasn't been an issue that we're serving who we're supposed to. Next slide, please. When we first graduated, there was a lot of about our collaborative management agreement. What is it? How does this work? Is it, got really confusing. And then everyone kind of took a step back and realized that it's not very much different from a collaborative agreement that you would sign with a hygienist. The Minnesota Board of Dentistry has a very nice outline of what needs to be in a collaborative management agreement. You just follow the outline and fill everything in. And then we have to sign at least once a year with every dentist that we collaborate with. Dentists can have up to 5 CMAs with a DT or an ADT. And then I think it's also important to note in Minnesota, our professional developmental cycle is the exact same as a dentist. We have to have the exact same amount of credits and the exact same way also. Next slide, please. Oh, really quick fun thing about the collaborative management agreement. When I've traveled to other states, it's helped comforted some people knowing that the collaborative management agreement allows like a dentist or a clinic to limit the dental therapist scope of practice in any way if they're not comfortable with a dental therapist doing something. At least to my knowledge, the last time I looked at all the scope of practices for dental therapists, at least in the state of Minnesota, no dental therapist has had their scope of practice really restricted other than a short term of like observation after they've achieved their advanced dental therapist. So restricting scope of practice is actually not super common since we have a smaller scope of practice anyway. Right, a few statistics. Next slide, please. Again, this is that study that I was referring to by the Minnesota Department of Health. You can actually see the amount of different studies done throughout this and what it kind of encompasses. It really shows who's working and where we're working and if we like our job and all that other fun stuff. So that's just a link, or you can just Google dental therapy, Minnesota Department of Health, and it'll pop up for you. Next slide, please. The University of Minnesota, Dr. Self and his wonderful team shared recent data with me. Currently, there are 114 licensed dental therapists that have graduated as of January of 2021, and 83 of them are certified as advanced dental therapists. We are practicing in over 70 different practice locations, which is pretty awesome. And we are recovering well from the pandemic. Before it started, and I think even now, there's more open positions available than there are actually dental therapists, which is really great. Next slide, please. This is from February of 2020. This just kind of breaks down to where we're practicing. I think a lot of people are surprised to note that the majority of us are actually in private practice. And then from there, it kind of goes into nonprofit and FQHCs, federally qualified healthcare centers, large group clinics, educational institutions, and hospitals. So again, thank you, University of Minnesota, for doing that. Next slide. And then this is kind of a geographical representation again from 2020. I think it's important to note that when you look at how state-based insurance patient population is dispersed within Minnesota, that's where the dental therapists are. About 60% of the state-based insurance patients are in the metro area and 40% are in greater Minnesota, which is where the dental therapists are. So we are serving and where we need to be and looking forward to doing more. Next slide, please. I had the privilege to work for Health Partners for 8 years. These are just some statistics. They found that dental therapists had about 78% production of a full-time dentist. We had a dramatic decrease in the wait time for patients. We had 11% increase in dentist production for just one of the dentists that we worked with. We had an increase in job creation because we had more patients come in, so we needed more hygienists and we needed more assistants. And I love this phrase from Dr. Nakagaki, who works with Health Partners, work smarter, not harder, which is what he found to be especially true with dental therapy. And they found that patient safety has never and has not been an issue. Next slide. And then this is from the head of Health Partners Dental. The DDS compensation package is roughly triple that of a DT, and the average productivity was only 9% lower than a DDS. So next slide, please. We'll get into this more on the panel, so I'm going to kind of move past the next few slides, but mainly this one is just, there have been no complaints or concerns presented to the Minnesota Board of Dentistry within the last decade. It's a well-accepted medical model with nurse practitioners and physician's assistants, so when patients hear that, they really haven't had any issues that I've ran across seeing a dental therapist, and it's already well established in the medical world, so why not the dental world? Next slide, please. Again, we can practice in a variety of different clinical settings. It's a master's degree, so some people are using that to teach and run programs. Christy Jo Fogarty, who actually will be on the second session, She was head of the Minnesota Board of Dentistry, and she is currently the past president. So yeah, there's a lot of fun things you can do with the dental therapy master's also, which is kind of cool. Next slide, please. We get to work with a lot of variety of populations and cultures. Again, one of the favorite things I find about dental therapy. Next slide. The education and prevention part of it that we get to help the hygienist with and the dentist with, because it helps so many times when a patient can hear things more than one time, is a great part of the job, and a lot of our schooling is focused around that, which is very helpful. Next slide, please. So again, we can just go through the next few slides. These are just kind of fun places and pictures of dental therapists that are working. Next slide. Yep. Just keep going. Mobile dental units are becoming more popular. We have one at where I work currently, which is very exciting. Next slide, please. New in Minnesota, the Metro State program moved to a new location. The University of Minnesota and Metro are working on CODA accreditation. It is a very long process, as for what I understand, and it is continuing to move. COVID slowed that down a little bit, but we're working on it and should be hopefully CODA accredited in the future. And again, we have about 12 states where dental therapy is legal now and within a decade, which is pretty awesome. So there's a short list for you there. Next slide, please. And then again, the Minnesota Dental Therapy Association was formed in 2013. It just helps dental therapists. We post job postings and just help answer people's questions from all around the country, and trying to do more things like this just to get the word of dental therapy out. Next slide. We're going to go through this in the panel, how to incorporate dental therapists into your clinic, but just be aware there's a lot of resources out there for you. There's a huge toolkit that you can look up that the Minnesota Department of Health and the University of Minnesota worked with. So again, if anyone needs these slides, feel free to reach out to me. Next slide, please. Salary is always a big question. The Minnesota University of Minnesota and the Minnesota Dental Therapy Association have been working on creating a recent compensation survey. We're hoping that'll be published in 2021. We're trying to get as many clinics as possible to respond to the survey before obviously it's published. So please look for that in 2021. It'll be very up to date, how dental therapists are being compensated, including the benefits, and we'll compare it with hygienists. And so that's something really fun that will be coming up in 2021 too. I think just for more of a basis, I just tell people that you can pay us about half of what you would pay a dentist to still give really high quality, people-centered care. Next slide. Have fun. And last slide, thank you. So I believe the next point of the presentation is just going to be video on a day in the life of a dental therapist. So you get to see my lovely face again and a few other new faces. And after that, I will introduce you to our panel.
Hello, my name is Andrea Jordan. I'm an advanced dental therapist and a licensed dental hygienist. I graduated from Metropolitan State University from their Masters of Science in Advanced Dental Therapy program in 2013. Why did I become a dental therapist? I worked in dentistry for many years as a dental assistant and then as a licensed dental hygienist. And during that time, I really understood the benefits of maintaining a healthy mouth and the consequences of poor oral health. I also had some volunteer opportunities that really opened up my eyes to this whole population of people who were not able to access care through traditional private practice model. It really made me think about what I was doing and why. About the same time, I came across some information from the American Dental Hygiene Association on the proposal for an advanced dental hygiene practitioner. That idea really stuck with me. the idea of taking my existing knowledge and expanding my skills to provide the next level of care for people who are struggling to find dental care. Short time later, dental therapy was passed in Minnesota, and I applied and was accepted to the Metropolitan State University Advanced Dental Therapy Program. I graduated as part of the second cohort from that program in 2013. I obtained my advanced certification in 2015 while I was working in a federally qualified healthcare center in Minneapolis. One of the things that happened during my time at that FQHC was the center received a grant to study the integration of medical and dental care. There, I partnered with their pediatric nurse practitioner. She would include me in her well child visits for all ages of children, infant through adolescents, and I would go into her exam rooms at some point during the visits. I would complete an oral assessment, apply fluoride varnish, and give oral health education to families who are often just coming to the United States and really not used to preventive dental care. We were able to schedule kids back for cleanings and restorative treatment because I had a small on-site dental operatory. We would often piggyback appointments with other family members when they were coming to the clinic to see other providers. This saved the family time and the cost of transportation. Eventually, other medical providers in the clinic began to include me during their adult patient visits. I would triage oral pain or concerns, and I would visit with pregnant women to assess their oral health or share home care information. Sometimes I would provide further care right on site. Sometimes I would refer to my collaborative dentist for more extensive care. This experience really opened my eyes to the many types of collaboration and partnerships that dental therapy could participate in. Where do I practice now? Well, about 2 years ago, a full-time teaching position opened up at Metropolitan State University, and the idea of a dental therapist participating in the teaching of dental therapy was something that really interested me. So now I teach full-time in the Advanced Dental Therapy program. I teach theory, clinical skills, and provide oversight during students' clinical care. How does my practice increase access to care? Well, my situation is a little different now that I'm teaching because I'm not involved much in direct patient care, but our educational clinic does provide care to patients at very low cost. We offer a full range of dental therapy procedures at our clinic and have partnered with several community clinics in the metro area to provide services that are outside of the scope of practice. This way, our students get to understand how partnerships can work within dentistry, both between clinics and between different providers. What do I see for the future of dental therapy? Well, there are so many growth opportunities and partnerships out there for dental therapy. As I see the profession being taken up in so many other states, I feel that we are really on the edge of really positive change in oral health. This is the way that healthcare should work, in collaboration. And that's really what dental therapy was designed to do. We can work in schools to provide care right on site to students. We can partner in medical clinics. We can access remote and rural and non-traditional settings, and we can teach. As this profession grows, there will be so many more opportunities that we haven't even considered yet. I feel really lucky to be part of this new profession. I see it as a really dynamic profession. I hope this gave you some new information, and thanks for listening.
Hi, I'm Abigail Helmbrecht. I am currently an advanced dental therapist at Dentistry. However, I have been practicing as a dental therapist now for 8 years. I graduated from the University of Minnesota, part of the second graduating class of dental therapists in 2012. Upon graduating, I started as my career as a dental therapist in Deerwood, Minnesota. I practiced there 4 days a week and lived more towards the cities during the weekends. I worked there for 2 years, and then I had my first child and looked for work closer to home, and I started working between 3 different practices at the time. Dental Associates in Savage, Park Dental, and Distinctive Dental Services in Howard Lake and Winstead. I loved working at all three. The Dental Associates I only worked at Saturdays for a period of time, slowly moving into Park Dental a little bit more often. I spent some time at Park Dental full-time as a dental therapist, not yet advanced, and after about a year, some changes happened within state insurance and they just couldn't keep me busy enough. So I accepted a full-time position at Dental Associates, and I worked there for about 2 years full-time after getting my advanced, really utilizing me to the top of my scope, working in a clinic by myself most of the time, with the dentist obviously available via phone if needed. I really enjoyed my time there. It definitely expanded my comfort being the only provider in the clinic. Having that responsibility taught me a lot. After some time there, I did start at Shifa Dentistry 1 day a week on Fridays, and I really found my home there. I now work there full time, 4 days a week, and loving every moment of it. We see about 90% underserved patients, the rest being commercial and cash patients. And really, I think it's where the dental therapist model has really proven itself to me. There's myself and 2 other advanced dental therapists there, with one dentist, the owner of the solo practice. Just a very busy clinic that the flow works right. Our group and our team, we all really use our scope to the best of our abilities and work as a team. That collaborative agreements that we've always talked about in school just has really found its niche there. Why I became a dental therapist is I wanted to help. I wanted to get out there and see what I could do and encourage others to take better care of their health and their needs, and to understand where the mouth and oral cavity kind of fits into all of that. I definitely feel like I improve access to care. I allow the dentist to practice at the top of his scope, working on implants and crowns and things like that, and encouraging myself. I'm encouraging patients more to take better care of their teeth, and to understand the link between the form and frequency of what they eat and how that affects their entire body. And then conversations about sleep apnea being related to grinding and diabetes and smoking. It just really gives me better opportunities to that. I see the dental therapist really making its mark on multiple different practice settings as technology becomes more available for dentists to work as more of a specialist, as focusing more on implants. Most of the dentists I see, they don't want to work on the restorative work all the time. They want to do implants and ortho treatments and surgeries. And now that technology has made it possible for those things to be more ease of access to the equipment, I guess is the way of saying it best, and the continuing education programs that are provided. I see dentists moving more into those practice settings, allowing them to open up the doors to different opportunities. I love being a dental therapist. I am so glad that I took that plunge at the University of Minnesota. So thank you, Dr. Lopez, for making that encouragement. I like that I am not the dentist. I don't have to do everything. I have the ability to, when I don't feel comfortable with a procedure, having the DDS be the caregiver in that case, not having the responsibilities of some of the things that I may be not comfortable with, is just wonderful. I love everything that we do and the opportunities that we've been given. So that's my story. Yeah.
Here's my clinic, Shifa Dentistry in Maple Grove, Minnesota. We got a beautiful view over there. Should we head on in and take a look? here we have our lobby with chairs sectioned off to encourage social distancing. There's 10 operatories in back.
Hi, I'm Katie Loviska. I am an advanced dental therapist. I was part of the first graduating class that graduated back in 2011 at the University of Minnesota. I did my undergrad. Perfect. Okay, I had a whole video. Everyone's heard about me, so all good there. I think we're going to move to the panel part of the discussion. So I'm just going to kind of let everybody introduce themselves. I'll bring through kind of one by one. I think, Sai, if we could give Jenny permission to use her camera, that would be great. I see Bree first, so I'm going to go with Bree. Bree, will you please introduce yourself and tell us a little bit about yourself?
Sure. Hi, I am Bree Borntrager. I was also part of the first graduating class at the University of Minnesota. So I have been practicing for almost 10 years. My background, as far as the clinics I work at, I have kind of been across the board working at community clinics, federally qualified health centers, and I am now at a smaller private practice out west of Minneapolis.
Awesome, thank you. I see Katie ask next, so let's go to Katie.
Hi, yeah, I'm Katie, and I graduated in December of 2017 from the University of Minnesota in dental therapy. Before that, my undergraduate degree is in nutrition. After graduation, I worked to become a certified advanced dental therapist, and I'm now working at a private clinic in the Twin Cities.
Amazing, thank you. Drew Christensen, you are up next.
Hey everyone, I'm Drew Christensen. I am currently a clinical assistant professor at the University of Minnesota School of Dentistry in the Division of Dental Therapy. I joined that in 2014. I graduated from the University of Minnesota School of Dentistry in 2013. Currently, I also practice a couple days a week when I'm not inside in the School of Dentistry, a couple days at a private practice, which you just saw Abby Helmbrecht or Abby show online there. So I am at El Shifa, and I practice mostly seeing children, but also adults and geriatric patients.
Great, and then Dr. Brian Quinlan, if you wouldn't mind going next.
No problem. Good evening, everyone. I am Dr. Brian Quinlan. I started my career in public health in 2008 at a FQHC in St. Paul, Open Cities Health Center. And in March of 2017, moved to Southside Community Health Services in Minneapolis. I've been a dentist since a long time ago, 1986, it's almost 35 years. And so that's roughly about a third of my career that I've been in community health, and worked with dental therapists pretty much from the beginning of from the inception of the practice in Minnesota. Hiring Bree, I think that was 2012 that we got together, yeah. And am now enjoying and have worked a lot with dental therapists. I would have to stop and count the number that I've worked with, and it's been very, very successful, and I'm very happy with it.
Awesome, thank you, Dr. Quinlan. We're trying to get Jenny's camera up, but until that happens, Jenny, would you mind just introducing yourself?
Sure. Can you at least hear me?
Yeah, I can hear you.
Great. Very good. My name is Jenny, and I currently work at Southside Community Services with Dr. Quinlan. I graduated from the University of Minnesota in 2016 for dental therapy. My history in dentistry goes way back to 1999 when I received my dental assisting degree. I did a lot of different areas in dentistry as an assistant. I worked in ortho, oral surgery, pediatrics, National Guard as a dental technician. And after about 10 years, I realized that I had more to give in the dental field. And so I went back to school to get my undergrad at the University of St. Thomas. And while I was in school at St. Thomas, I learned about the dental therapy program. And I knew it was exactly what I wanted to do. It met all the requirements of what I wanted to do as a provider. So went to the University of Minnesota and graduated in 2016.
Great, thank you. Sorry if you can hear my children in the background. Apparently they're having fun. Okay, and then so I believe that's all our panel for today. Again, we'll have a bit of a different panel next time too. So I'm just going to go through a few questions, let everybody answer, and then at the end we'll have time for a Q&A session. We'll attempt to get to all of your questions. If I don't, I will take down your name. You can write down my email. Please feel free to flood my inbox, and I will get you the answers that you need. Or we can work on that next time at the next live session too. So why did your dental office decide to include a dental therapist? And I think I'm just going to kind of go in order here. Katie, ask, why don't we start with you, since you kind of have a unique standing on that too.
Yeah, so I graduated again in 2017, which was also the same year that the clinic I work for was founded as a clinic. And they had purchased an already existing practice in the city of St. Paul. And since then, they have grown to have 4 separate offices. They have had dental therapists working all the way since the beginning of the company. And I currently run one of the 4 locations. And in our company, none of the dentists do any of the fillings. So each of our 4 locations has a dental therapist working at that office to take care of everything in the dental therapy scope to provide the dentists to be able to do the procedures they'd like to focus on.
Amazing, thank you, Katie. Bree, why don't you go?
So the clinic that I currently work full-time at, the dentist that I work with had his main office in Glencoe, Minnesota. He had a desire to find some way to use his dentistry to reach the underserved community in the Glencoe area. His practice was really, really busy at the time, so he couldn't see himself kind of expanding the tasks that he has. So he and I started talking, and I kind of told him what I do as a dental therapist. He wasn't super familiar with dental therapy, but I told him kind of my background and what I'm able to provide patients. And we decided to open up what we call a satellite clinic in a neighboring town. So he kind of left that clinic up to me to get it up and running. We took over for a dentist that was retiring, kind of revamped the place, gave it a facelift, and started accepting patients in March of 2018. Since then, we've been able to we see about 1,000 new patients a year, and we've expanded from 3 chairs to 5 chairs. Initially, I was the only main provider, so it was myself and a hygienist, an assistant, and 2 front desk staff. And we've been able to basically double our staff since opening, and bring on a full-time dentist to our staff as well. So the main reason he brought me on to the team is basically he wanted to find a way to meet the needs of the underserved community in his area, but wasn't able to do all of the work himself. So.
Great, thank you, Bree. Drew, why don't you take a crack at it?
Sure. Mine is a little bit similar to Bree's in the fact that my dentist wanted to kind of create an environment for people to be able to be accepted, no matter what their insurance was, whatever their background, culture, ethnicity. But he started that before I arrived. And when push came to shove, he was hiring associates and he was trying to keep them on, but he was the one, as being the owner, dentist, was doing a lot of the crown and bridge, extractions, ortho, and the associate was kind of being the one doing more of the basic restorative and the exams, and they would move on as associates do. So he's trying to fill that void as more of a permanent solution. Essentially what I did is I contacted my dentist and said, hey, is it an opportunity for me to just come take a look and see how I could help? And this was a time in 2013 where we're still selling dental therapy to Minnesota dentists, kind of telling them what we can and cannot do. So we sat in his office and he told me about his schedule and talked about he has a single column for himself that he considers his dentist work, where it was the crowns, bridges, ortho, extractions. And then he had his other work, which consisted of the restorative care, pediatric stuff that was kind of on, I wouldn't say second fiddle, but was something that wasn't in his cup of tea. So he showed me the schedule and said, this is all yours. When can you start? And so he was super excited to hear that I could do most of the things that he didn't want to pursue as a dentist and use his skill set. So it's been really a wonderful experience just seeing him grow as well as a dentist in his skills and taking more CE to provide better care for our patients. So that's that.
Great, thank you, Drew. So Dr. Quinlan and Jenny, Dr. Quinlan, if you want to speak a little more to this, since you were part of the integration of dental therapy at Southside Dental Care, and then Jenny can follow up.
Sure. So at the inception of dental therapy, I had had quite a bit of exposure to it before it even became law. And I thought it was the perfect thing for the FQHC I was at. That office was not seeing very many children, and we were in a highly underserved area for children. And it wasn't due to a lack of effort. It's just that no particular dentist really focused on that. So I wanted a therapist then, as I heard about them, to come in and focus on the children, but I didn't limit the scope of practice to that. So I called up a few of the therapists that I had met through the University of Minnesota and various programs they did, and hired Bree for that. But I didn't limit her to just children. I wanted her to be a part of the whole practice, and that had worked very well. So she was seeing plenty of emergencies, which was very big in the practice at the time. She was taking care of fillings, and a big need of the practice was extractions. And I was pretty much the principal person doing extractions. What was very helpful with that is Bree could screen the patient. As a dental therapist at the time, I would go in, do the exam, and then if I agreed to do the extraction, she could numb the patient. And it's been a system that has worked really well, where basically I wind up having a second chair with somebody who can man that chair, and I can keep my focus on my main chair. So from that, I think just a lot has grown out of that, utilizing the skills of each dental therapist.
Great, thank you, Dr. Quinlan. Jenny, anything to add? I know you've been with Southside Dental for a while now.
Yeah, I started at Southside right out of school, and I was very privileged to join Southside once Dr. Quinlan had been there. Maybe it was a couple months, and so he was really the one that brought the vision of dental therapy to Southside. And so now currently I'm one of 5. There's 5 of us working there, 5 dental therapists and 5 DDSs, and it really has expanded the patient care that we can provide.
Yes, I agree. Awesome. Thank you, everybody. That's the first question here. How is the integration of dental therapists within your office been communicated to the community and to your patients? So how are you making it simple to explain this to patients and to your community that this is what dental therapists are and how this is how they're being utilized? Bree, you want to go first?
Sure. So I have never really had much of an issue explaining what I do to patients. A lot of times, either if I'm going in for an exam or if I'm going in for treatment, the hygienist or the assistant will explain, like, Bree will be in a couple minutes, and usually they explain that I'm an advanced dental therapist. And most of the time, there aren't a lot of questions about that, but we will always introduce me as an advanced dental therapist. Sometimes there are questions, mostly just what is that? And either my team will explain or I will explain what it is I do. They are all very good at explaining what it is I do. And it's never really been an issue. The community that I currently work in it's a smaller town. So most of them kind of know what I do and how I function as a provider. And so it seems like things work really well and we have a really good relationship between all the staff and the community.
Thank you, Bree. Drew?
Since 2014, being in that clinic, it's been a learning curve for most of our patients. Most of our patients were used to seeing their dentist who had an established practice for 5 years before I came on. And so there was a large learning curve for about a year for providers to be able to understand what I did as from a hygienist standpoint, assistants and my dentist. They used to just say we're the filling specialists. And so we had to kind of tone that down. Every time you throw a specialist word out there, sometimes people think like, oh, you must have went and did something different. And it's like, no, it's just a different type of provider. So nowadays, though, our patients are accustomed to scheduling and knowing that if you're with a dental therapist, you're probably going to have a smooth 45-minute to an hour appointment. If you're with our dentist, you're probably going to do something a little bit more major, a little bit more invasive. But in equal parts, you're in good hands either way. So a lot of the questions that I do receive are very minor in terms of what can you do, or where did you go to school, for how long, why didn't you go to dental school, or are you going to help me through my anxiety, as we kind of touched on earlier. But nowadays, with the 3 dental therapists that we do have, that conversation is pretty smooth. We had our little elevator speech, so nothing too hiccupy, just like Bree commented on.
Great. Dr. Quinlan and Jenny?
Well, currently, similar to Bree, there hasn't been any problems at Southside with people and accepting dental therapists. It seems the community and people already understand and know about them. At the beginning at Open Cities, I really didn't get any trouble with patients. I would say, now I'd like you to see Bree, my therapist, who will do the fillings. And they'd ask, what's that? And I'd say, what is she? But I'd let them know what her qualifications were. And most just shrugged their shoulders and said, yeah, okay. If any of them had any problems, I would merely say, well, I'd let her do a filling on me. And well, lo and behold, one day I needed one and I let her do a filling on me. So I got to say, I let her do a filling on me. And once they heard all those things, patients were quite happy with it. The FQHC also had medical and vision and chiropractic in the building, amongst others. So at a all clinic staff meeting, I did present what dental therapy was about the education, something similar to what we've done tonight, a lot shorter, just to let people know what this was all about. And there was no pushback from that because there were nurse practitioners and PAs working at that office already. So it had very wide acceptance.
Yeah, just kind of piggybacking off of what Dr. Quinlan was saying at Southside, I honestly have never had any issues that I can even think of about somebody not wanting to see a dental therapist. If anything, you know, when I come in and I introduce myself as just Jenny rather than Dr. Myers or Dr. Jenny, you know, sometimes I'll get a question like, oh, just Jenny. And, you know, then that kind of preempts the conversation. And then we talk about, you know, what a dental therapist is and my education and my role in the dental field. And everybody has been very accepting of it. And I think, you know, that starts with having a good DDS who kind of preempts everything and introduces the dental therapist. I know on a daily basis, usually, you know, when Dr. Quinlan does a pediatric exam, and he'll talk to the parent like, you know, I would like to have your child come back to see Jenny, the dental therapist. And so he'll call me into the room where I can meet the child, and it just starts off a very good relationship with that child and good future visits. So I have never had any really big issues at all.
Great, awesome. Katie?
Yeah, so a lot has already been said. Totally agree with my clinics too. We've never really had a problem with anyone questioning what an advanced dental therapist is or having problems with working with one of the therapists. Really overall, it kind of started with our assistants just handing and transferring the patients. They're always very clear on who is coming into the room next. I am always introduced with title, and so then they just know who they're working with. And again, get a lot of the questions of, oh, what's that? But more of a curiosity of, oh, I didn't know that existed than anything else.
Awesome, thank you. I'm trying to answer questions while we're doing this too. So, what types of patients does your dental office or does your dental therapist see? Are they different from your general patient population? Is it a mix? Just kind of pursuing towards that. Drew, would you mind starting?
The patients I see, I do consider the general population. In Minnesota, it's home to many different cultures and backgrounds and ethnicities. So in my typical day, I can hear 6 languages being spoken, from Somalian to Spanish, Russian, English, Ukrainian, Hmong, many different languages. So to me, that is the general population. Working closely with within the 30 minutes of the downtown Minneapolis, we do get a lot of different backgrounds. And so that general population to me is pretty normal. But most of my patients are recent immigrants or second generation immigrants. So TIVA will serve those patients and really incorporate them into a new dental home and into dental care per se. Allows them to pass that on either to their children or just know to start the process of taking care of your teeth, which is something sometimes they're unaware of. But I would say in a typical day for me, when I'm working with my population, is no different than when I worked early on at Health Partners. It's just you get different breeds of people, different walks of life, and I think that's what keeps us on our toes as providers, is we get to experience all those cultural and diversity encounters. So really beneficial for me.
Sorry, great. Katie, you want to go?
Sure. So the majority of the patients that I see at my clinic are a pediatric population, and that just is where the majority of my scope is as an advanced dental therapist. But I see the same population as any of the associates or dentists in our company, and the clinic sees about 90% MA patients.
Great, thank you, Bree. I'm having fun with the button.
I've been really fortunate my whole career. I have not been limited to a certain like age range or a certain patient population. So the population of the clinic is the population that I see when I'm practicing. So that ranges from ages 0 to, I don't know, the oldest patient I've seen somewhere in the 90s, I think. But I've been fortunate to be able to see all age ranges. Some offices that I've worked at, I've seen a heavier pediatric population just based on the patients that we are seeing in the clinic. Sometimes it's a more needed service based on what clinic I'm in. So there have been clinics where I take on the majority of the pediatric population, which I'm very happy to do. The clinic I am currently at, I started out as the only provider there. So obviously I saw all the patients. Now we have a full-time dentist, but I see all of our pediatric patients now, and she just doesn't prefer to see pediatric patients, but she sees more of our elderly patients. She's just, I think, more comfortable seeing that patient population. She is also the one doing our dentures and removable. So that patient population is just a little bit better geared for her scope, but we kind of all see all ages.
Dr. Quinlan and Jenny?
So I never limited, as a director, the therapist to any specific population. The only thing I asked them is just stay within your scope of practice, and there wasn't any problem there. They knew that and they stuck with it. Anything that they could do to help out a patient was most welcome at the practice. And I know at Southside, and she'll tell you more about it, but Jenny has taken on a lot of the pediatric population. So the phrase "my friend Jenny" has come out of my mouth many times to tell them who they're going to see. But I can make my friend Katie too soon if you want, Katie. So it's been fine, and I can just say the same thing as Bree, that it's not that I don't want to see children, but when I have people that have focused their education and their scope of practice with children, and also on a lot of the preventive care, I think it's just best to send them there and let me, as Bree mentioned, take care of dentures and extractions and other things.
Yeah, so at Southside, like Dr. Quinlan was saying, I kind of have taken on the role as the pediatric provider, but I still do see, patients of all ages, all types. We see a lot of patients from nursing homes. We work at an FQHC, so there's all types of different patients that come in through there and of all ages. So with the peds, I definitely, I really enjoy it. It's my passion. There's some days where I'm with all children every day, all patients throughout the day, nitrous patients. Some of them can be really, really difficult, but I think that, as time has gone on, it has greatly reduced the amount of patients that we've had to refer to peds. Our patient population with the kids, they just don't have a lot of places to go, a lot of choices. And so it's really rare that we have to refer a pediatric patient, maybe like once a month. And those are kind of the extreme cases, with advanced medical conditions that would be best served at a pediatric office under general anesthesia. But other than that, we really try to see all kids, and I usually get the majority of them. And Katie is going to be, she's a great help as well with the kids. And then once the little one comes along, she'll be joining more with using nitrous more. But I really enjoy seeing the kids there.
Yes, I am looking forward to seeing more kids. That is one of the favorite parts of the job for me. So I'm going to try to help Jenny out here once I can pop this little guy out. And then Just to kind of answer some of the questions we've been getting through the Q&A, Drew, would you mind kind of just voicing, some people are a little confused about the 50%. If you work in a designated shortage area, does a 50% qualify? Would you mind just answering kind of that question for us?
Sure. So the rulings and the legislation that's written behind where dental therapists can work is semi-unique to Minnesota, is that it gives us some parameters and qualifications on where a therapist can actually provide care. Dr. Frank Catalanato commented in the Q&A about what is the 50% and isn't that subjective to the dental health shortage areas? And it is. When you do provide care in a shortage area that is deemed by the Minnesota Department of Health, you then don't have to abide by what we call that 50% rule. You actually are qualifying and serving an underserved area rather than providing care at a 50% Medicaid patients. And they did this, from my understanding, to help limit the amount of localization of dental therapists, promoting more rural communities and rural outreach for DTs. But if they do serve in the Twin Cities area or in an urban population like Duluth or Rochester, that the patient population is still focused on that underserved and that population that is going untreated. So that's where that 50% comes in. I think the biggest takeaway is that, I think Dr. Catalanato again commented on this, is that the monitoring of that 50% is not necessarily done yearly, weekly, annually, monthly. It's done on a, where are you working? We all sign a collaborative management agreement and send that into the Board of Dentistry. And we describe what populations that we're seeing. So that's written into our agreements, and we're aware of the patient population that we're seeing. I haven't heard of or noted anyone that hasn't been doing that. I think because there's only so few, of about 114 of us, that if somebody was doing something that wasn't in there, that would get caught pretty quickly. So the limitation is there. Not all of us agree with it, and we don't all understand at the moment why it's still there. But as legislation and rules are put in place, they are hard to change. Once you open up Pandora's box, other things can come out. So that's where we're at right now. I would not like to see that in other states, but that's for another conversation.
Thank you, Drew. I think that helped clarify a lot. And again, as I kind of pointed out in the presentation, this has not been an issue. No dental therapist has had an issue working, where we were designated to serve with the patient population. I'm going to skip the next question because I'm pretty sure we've answered that pretty well. What are some roadblocks that you have encountered as a dental therapist or having dental therapy in your clinic, either starting out, because there's some people watching this that are thinking about incorporating dental therapists, to some that have been working, with them for years. Does anyone want to go first?
Sure. So the biggest roadblock that I've encountered has been dentists. When I made the presentation at the FQHC Open Cities Health Center, I wasn't completely truthful. There were a few people that didn't agree with me at all, and that was just the dentists. And they wound up leaving the practice over all this, and it just didn't make sense to me. I've also heard other things from other dentists and chatted with other dentists, and they just seem to struggle with the idea of it. I don't know exactly what it is, but I've made it clear when we hire dentists that we have dental therapists there. They have to be on board. They have to sign the collaborative management agreements, and that the dental therapists are very much a part of the practice, just like they are.
That is a great point of view from a practicing dentist that has been with dental therapy. Just personally, I remember standing in lecture halls at the University of Minnesota when this was passing legislation and having people, jump up and shout and scream. And the way that the University of Minnesota did it, where the dental therapists, train and practice, and they're in classes with the dental students and with the dental hygiene students, I think that was a very important step. So by the time that they graduate, dental therapy is already part of dentistry, and they're used to having that provider there, and they know their scope of practice and what they can do. And I personally can say that it's changed dramatically over the last 10 years, but then you go to a different state, and it's kind of starting all over again. It's just this vicious telephone game of what they're hearing about Minnesota. And so I'll let someone else speak. Katie?
Yeah. So the only roadblocks that we've really had has just been scheduling and utilization. So how we can figure out how many assistants I'll need to optimize my schedule versus how I can start taking away more of the workload from our associates now that I'm an advanced dental therapist. So I feel like our clinics got very used to working with a dental therapist, but then I had to receive the certification to be advanced. So now we're kind of starting that process over again of, wait, there's more, and here are these other things that I can do. And so just kind of scheduling has been really our only roadblock.
Bree?
Hey. So from my experience, I have been pretty lucky that Dr. Quinlan brought me on. And so I haven't had a lot of issues in the workplace for the most part with dentist acceptance. Dr. Quinlan was kind of able to take me under his wing and shield me from some of that, I think. So I was lucky in that sense. In the practice that I'm in now, I think our biggest roadblock is billing issues, actually. And not that we can't get reimbursement, it's more so some of the hoops that have been put into place in the context of medical assistance billing. And joining a practice with staff that is not used to medical assistance billing, it's kind of a learning curve to figure out what we need to do and what codes we have available to us that will get reimbursed by the insurances that we accept. I was able to learn a lot of that actually at Open Cities when I was there trying to navigate, how do we get reimbursed? What services are covered? What services are not? So I learned a lot of that in my first practice. And kind of along the way, I picked up kind of the ins and outs of what medical assistants will pay for and what they will not pay for. So when it came to kind of starting a new practice and trying to navigate accepting a large medical assistance population in a private practice setting, we were able to navigate medical assistance billing and making sure that the services we do provide get covered. So this is kind of 10 years in, and I'm still learning, and medical assistance insurance stuff is changing constantly. So it's kind of a constant battle, but it is a task that I am very willing to do in order to treat the patient population that we do treat.
Great, thank you. Drew?
You guys answered a lot of those questions about roadblocks, but I guess the last one that I think all of you may have heard as therapists is, do you think this will ever catch on? I mean, I think I'm constantly hearing that from not just Minnesota dentists, but dentists from throughout the country. And so when I hear that question, I really kind of go to experiences of patient experiences. Those are hard to refute. I hear the term, oh, it's not making an impact to the whole Minnesota public. There's very few of you, you're not making the larger impact that they thought they were, you're not in rural. But then I usually just tell about patient experiences and how, the close to probably 100,000 patient visits so far offered by dental therapists, and probably more, those people have been impacted. So even though it's a small percentage of the overall population of Minnesotans, I think that population being underserved, finally being served and paid attention to is one of those where I kind of challenge that roadblock of, yes, I believe it is catching on. For those that are getting care that I'll be seeing tomorrow, they think it's catching on. So I'm going to stick to that. I'm going to stick to treating the patients that need it and kind of go from there. So.
Great answer, thank you. We are going to do one final question from the panel, and then by that time it's going to be 8:30. So you should have received your CE accreditation, I believe Joe said, through the email. If you didn't, please let us know. Sai is going to put up a contact slide if possible, so people can write down information and email questions. Also, I'm going to stay on and try to answer as many Q&A questions. We can also address the questions through email or at the next live session also. And again, thank you everybody for coming on. We had upwards of like 60 participants, which is amazing. And it makes me so happy. And I was very, very excited. So thank you all for your time. That is truly just an honor. I really, really do appreciate it. And go dental therapy. Okay, so last question from the panel here. What advice would you give a practice that is considering adding a dental therapist to their practice? Who would like to go?
Dr. Quinlan would be really good to start this one. He's had experience.
Well, I'd say the best advice I can give is to understand what dental therapy is all about, what the laws and statutes will be of your state. Understand that it does have a role in the practice, that it can be helpful. A lot of the roadblocks or dissension I've heard from other dentists seem to only be based on pride. And I'll go back to what Drew said. It may have been a small percentage, but those are people that probably wouldn't have gotten the care if the dental therapist hadn't been available to do the care. So there's definitely a role, and I will disagree with Drew. It's not catching on, it's caught on. It's working. It's a good thing for the state. And I see the people very happy with what the therapists are able to do, and I'm very happy with it too. Oh, one other thing, and just be sure to let the therapists work to their scope. I made them providers just like a dentist, gave them an assistant and said, you'll get a schedule, take care of what you can take care of. And watching them just thrive and go has been great. And I won't take the credit for it. I thank Bree for saying something nice about it with me, but they've done it on their own. And they've been a great profession in Minnesota. They've been very high class, and I'm glad to be affiliated with them.
I can say something too. I think one of the biggest questions I got when starting a private practice satellite clinic accepting medical assistance insurance was, is this financially viable? And it was something that I had kind of worked out in my head. I knew how much I could produce. I knew roughly what MA reimbursement looked like. I did some research on what our overhead numbers might be. And all of my calculations led to the answer of yes, it can be financially viable and even financially profitable, but I didn't have any data to support that. Now we are about 3 years into our clinic, and we see about 50% medical assistance, and then the other 50% is commercial insurance patients or self-pay patients. Our first, I want to say first year and a half, we averaged about a $27,000 profit each month, which kind of surprised, I think, all of us. I don't have the most recent numbers now, but the clinic has been, our location has been very profitable, and at times helps float something like an expansion of our other clinic, our Glencoe clinic, which was the main clinic. So the owner of both clinics has been able to use the profits of our clinic that sees about 50% medical assistance to help fund an expansion of his clinic.
Awesome, thank you. Katie, you've kind of been a big part of dental therapy and starting that in a clinic.
Yeah, so a lot of what my clinic did before opening as a company is they used a lot of the resources presented to us from the previous years already different clinics utilizing dental therapy. So I think in the slideshow, it said there's about 70 different clinics and practices that are currently utilizing dental therapists. And chances are, if you have questions, these clinics have already had these thoughts. And I'd say to continue to reach out to like the Minnesota Dental Therapy Association, or I know lots of times any dental therapist is as passionate about expanding dental therapy as they are the dental work that they're doing. So I've done multiple just informational interviews, just answering questions. So I'd say if you have interest, don't be afraid to ask.
Awesome. Drew or Jenny, anything to add?
Jenny, you can go ahead.
You guys basically answered all the questions, all the ideas that I had. You know, advice is just have an open mind, and, you know, educate yourself about dental therapy. Like Katie was saying, you know, we're really enthusiastic about the career and we want to get out there. If you guys have any questions, email me. I would, you know, be happy to answer any questions, or at least lead you in the right direction of, you know, somebody who would know the answer. But I really think that going forward, dental therapy will be expanding throughout, and I'm really excited to be kind of one of the pioneers in the forefront here, helping.
Drew?
Just to piggyback off of all those comments, I think that the main theme was reaching out to dental therapists and reaching out to offices that currently or have had a dental therapist before, because those roadblocks and those transitions can be rough. They slow the amount of time that you can actually get a dental therapist in a working chair, because that's why you want them there in the first place. But I think we're at a time where everyone is so ready to share their story and so ready to incorporate dental therapists and be those pioneers, that if you have questions, you're probably going to get 4 or 5 people at least wanting to respond back to you with how they did it or how they want to do it. So you're going to have different experiences, and you may have different questions that other people can answer. So obviously reaching out to the Therapy Association, as Katie responded with, I think is a great starting first tool. But just being on the forefront. Again, as Jenny pointed out, this last little bit here is that it is going to expand. We can already see it moving to other states. Even this year, in 2021, we're going to see quite a few more states put up more legislation. And for me personally, for anything I'm doing, I'd rather be in the know than say I don't want to know about it. Because the more you know about it, the more you can make your own personal opinions and judgments on it. So being in the know is something that I think will make this profession excel, as well as make it better as we proceed forward. So.
Awesome, thank you. Well, it is right at 8:30. If any of the attendees or panelists need to go, it's getting pretty late at night. I know most of us have to work tomorrow. Please feel free. I will stay on if anyone else feels like, and just answer a few more questions. Otherwise, I believe the University of Minnesota is kind of keeping track or helping me too, and I'll try to answer as many questions that I can through contact information that way, or else please join the next session and we will have more time to answer more questions. It's pretty much just going to be a panel next time, which will be great. I think, hey, Bree, are you still on? There was a comment that, oh, where'd it go? They're sad that we don't have a national standard for DTs and ADTs, which could include the Alaska model as well, so that dental therapists can travel the country just as dentists and hygienists can. Can you help answer that?
I don't know exactly how to answer this question. She's asking me, I'm the current president of the American Dental Therapy Association. So we are in collaboration with all the dental therapists across the nation, which includes representation from Alaska, Oregon, Washington, Idaho, Minnesota, and now Maine. So we all are able to communicate and find out what everybody is doing. We aren't able to just jump over to another state necessarily to practice dental therapy. Each state has passed their own legislation, and depending on your training, you may or may not be able to go to a different state that has dental therapy. But those are all questions that the American Dental Therapy Association can answer for people once we talk to our representatives and find out some of the details of the legislation.
And it is coming. A lot of the DHATs have been able to come down to the lower 50 because they're working through tribal associations, as I understand it. And then Maine actually figured out how to license dental therapists from Minnesota to Maine. So it is coming. I kind of constantly have to remind people that we've only been around for a decade, so we're still working on it. We have to be recognized by working for so many years by different associations, and so that's something that University of Minnesota and Metro and associations, like, we're constantly working towards becoming recognized as a profession. Also, I don't know if Drew had anything else to add to that, but
Good.
Dr. Quinlan, you still on? Yeah. There's a specific question to you. At your FQHC, is it still a rule only one provider per patient per day can be reimbursed, i.e. that the clinic can't see both a physician, a dentist, and a dental therapist on the same day? They're assuming you're still encounter reimbursed. We'll go over this a little bit next time too.
Yeah, from what I understand, a patient can be seen in medical or vision or behavioral health and still be seen in dental, but any visit within the dental department with whether a hygienist, a therapist, or a dentist we'd only get reimbursed for one of the visits. But that hasn't really gotten in our way.
Trying to get through these. I'm curious, is the dental therapist employed by the dentist or contracted? If the latter is true, does a DT hire their own hygienist and assistants? Bree?
She left. She had to go.
Drew?
I guess I can speak on behalf of what I've heard or what I've seen. Most, if not 99% of dental therapists that are working are either salary or hourly and not contracted by a specific company. Katie, you may have another opinion on this about how you're working in your practice, but I know that there is some opportunity to be contracted by a certain company and work somewhere, but you wouldn't be able to supervise your own hygienists and assistants without collaborating with the dentist anyways. So that would be, you wouldn't be the one that's solely providing and caring for their well-being in terms of in the office and things like that. You still have a CMA with the dentist.
Great, thank you, Drew. Pretty much the same. Most of us are, I believe, hired. I don't think a lot of us work for a contract as far as like a dental hygienist can float to, and dental assistants can float to. I know that's something that's been brought up a few times, but again, we're having a hard time filling the open dental therapy positions as it is. The class sizes are small for a reason. The University of Minnesota, I'm on the admissions committee. There's only 7 per class because that's how many dental groups are in the school. And so having one dental therapist per group helps with patient care, and we don't want to flood the market by any means. We want to make sure everybody's well trained. Same thing with the Metro program. Usually there's only about 5 or 6 students per graduating class. So that's why there's kind of a limited number of us right now, but we're growing, which is exciting. We'll probably go through a few more questions, but again, if you need to leave, please do. Does being a public health dental hygienist play into any consideration in shortening the full-time program? The Metro's program, I believe, Drew, is only 18 months. So it is a very accelerated program, and they've already gone through the dental hygiene schooling to do that. And then I think 3 years for a master's and a dental hygiene bachelor's is very, very reasonable, but again, it is a full-time program, so coming into it doesn't necessarily shorten the schooling at all.
And just to add to that, Katie,
Yeah.
You noted that in 2015 and in early 2016, CODA, the accrediting body for all programs, has come out with standards for dental therapy. So moving forward for any programs, there will have to be an advanced standing for students that do have existing education within whatever allied profession they have. So the program would have to specifically have an advanced standing plan for each of those students that do come in. So as you may have taken, say, for instance, perio as a hygienist, if it wasn't up to the same standard as the education program that you're currently in, they may or may not have you retake that course. You're going to do really well in it, but the transfer of credits and the way that CODA works is to make sure that everyone is receiving the exact same education and given the same opportunity to perform those skills. So yeah, advanced placement comes along or goes a long way when it comes to accreditation. So
Awesome. Thank you. I hope that answered that question. Do you find revenue per encounter decreases with time for returning patients, i.e. the patients return year 1, year 2, year 3, etc.? I can just say from personal experience, that's the dream, that's our hope, is that what's going to happen as patients are able to receive care. And I've seen it numerous times where we start, it's with this patient population, it's usually not just like, oh, you need one filling on this tooth, it's a full quadrant dentistry. And so, you know, if we can get patients stable and go from there, then, I mean, that's what our main job is, I feel, is the prevention education part of it. Also, if anybody else has anything to add about that. What do you think are the most important things schools should keep in mind while developing a dental therapy program? Drew?
I feel like I'm speaking a lot to these questions. If anyone else wants to jump in, go ahead. But keeping in mind is that, again, referring back to CODA, that there are standards for dental therapy now. This was something that was really huge for our profession, is that it set the standard that we are at the same level of importance and accountability in terms of the dental profession. Previous to that, it was only board certification and authorization. So it could vary from state to state. But in 2015, when that came through, that really set that standard as here's the level of education everyone needs, and it's monitored. So for schools that are starting or looking into this, please reach out to existing schools. We've gone through a lot of the jumps and hoops that need to happen. We want to avoid that for those who are starting or are trying to make a new program. We want this to be as streamlined, as easy as possible for you. So I've had many encounters with educators from Vermont, Washington, Alaska, just collaborating together and finding out, you know, the do's and don'ts. So please don't hesitate to reach out. No question is a stupid question, and no question will go unanswered. You know, we'll find you a resource or find you a way. So networking is going to be your best friend when it comes to this. Don't try and tackle it on your own.
I just kind of wanted to talk about a different perspective of, you know, standards for the school. Having gone through the schooling at the University of Minnesota, I thought that they did a fabulous job with kind of intermixing us, I guess you could say, or not separating us. All of our classes were with the dental students and the hygiene students. And when we were up in clinic, you know, we were intermixed right in with the dental students. And I know when we were in pre-lab, our table was, you know, right with all the other dental students. And so they could see, you know, that we were held to the same standards, the same grades. I know the class behind me, the university was going under some construction, and the dental therapist got separated to a different, just a simple different room during pre-clinic. And, you know, there was some kind of talk, rumors, you know, going around within the dental students that, you know, they got easier grading and stuff like that. So I think it's just really important to keep everybody intermixed and have everybody combined. And then just like Katie was saying, you know, then when everybody graduates, it's just normal. We're just another part of the team. And I think it really helps.
Yeah, I fully agree. There's just one more question here, unless anybody else has anything to input, either from a student perspective, going to school.
Well, as somebody who was interested in hiring dental therapists, I was very impressed when I heard that the dental therapists were being taught the same thing, just as Jenny had told us. So that really made a difference to me. And then realizing that the other dental therapy program in the state didn't have a dental school or dental students there, I just merely gave them a call and took a visit over there and found out what their program was like and how they handled things, and found out that their standards were as high as the University of Minnesota's. So, and these were all very new programs. I don't know what standards were in place then, but I was very pleased with both of them. And so if it's a program starting up that's freestanding without a dental school, just keep the standards up as the dentist students would have.
Great. I think we've actually managed to go through most of the questions in the QA, and I know we're rounding around 8:45 here. So unless anybody has anything to add, or anything pops up in the QA here that anyone feels really needs to be answered, I kind of want to let everyone get on with their night here. And again, thank you panels and attendees. This was so amazing. You can, again, like Jenny said, tell how passionate we are about dental therapy. So yeah, does any of the panelists have anything to add? Good. Awesome. Okay, I don't see anything else popping up in the QA or the chat. So with that, I would just like to say good night, everybody. Again, thank you for your time. This has been amazing and refreshing, and it always energizes me to talk about dental therapy. So yeah, have a good night. We appreciate it. Thank you all.
Thanks, Katie.
Thanks for all who attended.
Thanks,
Appreciate it.
everyone. Yep. Bye-bye.